Anton, thank you.
Okay, so when I was asked to give this talk, I felt like somebody had been put into the lion's den. So first of all, I'm a stranger, I'm an outsider, I'm not a Latin American. All my background is from Eastern Europe, and I've lived all my life in the UK, looking at health models from countries close to me. However, I thought it might be useful for you to have an outsider's view. Sometimes it is good to see what other people think of what you're trying to do. And so I've got this great title, and I'm going to thank the people for giving it to me in a minute. You'll see who, about integration into national global health systems. Universal health care, we could call it, a UHC, and you'll see this used quite a lot by me. So you can see here a few people you might recognize from Mexico who wrote in JIS here, in JAID, sorry, HIV and non-communicable diseases in Latin America, a call for an integrated and comprehensive response. So it's an excellent paper. I advise you all to go and read it. So what's the background to this? So there is this quote from the World Bank: whatever path countries choose, universal health coverage is key to prevent people from falling into poverty due to illness and to give everyone the opportunity to live healthier, more productive lives, regardless of ability to pay. And every single one of those words, I think, should ring true for the whole world. Okay, so this is not just something I'd like to say about Latin America, it's the same in my country too. So, the AIDS epidemic, it's not really on track. I don't know how many of you think that by 2020 we'll get to 90 around the world. Some countries will. It doesn't mean that they will end AIDS by then. They still have an incidence of HIV infection. So, is there something more we can do to help things get towards the so-called targets or benchmarks? So, if the AIDS epidemic is not on track, if it's not going to get there, then there are two questions I want to pose in this talk. Number one, will the future of the HIV response depend on finding opportunities for integrating our HIV services more closely in other health services rather than seeing them as a separate thing, including social insurance schemes designed to expand health coverage? In other words, we put HIV into the whole mix. We don't look at it as an exclusive condition that we have to deal with. Will the HIV approach of being multisectorial, inclusive, engaged with civil society, emphasis on equity and human rights, all these things here we're really good at, yeah? Galvanization of innovation, foundation of global collaboration and problem solving, be preserved? So if we decide we're just going to make HIV like diabetes or asthma or something else, if we do decide to put it into a global health situation, will all these great things that we've led on and are still leading on today, will they be preserved? And will they actually be mainstream so that the diabeticians go, wow, this is fantastic what you guys have done. We can learn about it. I was in Moscow in November. The TB people were using no decision made for us, without us, no one left behind. They were using all the HIV slogans in tuberculosis, which I thought was fantastic. Except for there was only one small session in 2.5 days on HIV and TB, which wasn't so fantastic. But still, they are using the slogans. So, where has this happened? South Africa has moved to this already. Universal health coverage now. The HIV program's been integrated into the general health coverage. And Kenya. So they've been, alongside HIV testing and screening, they've also been looking for diabetes, hypertension, and other non-communicable diseases. And I must ask myself, in the HIV clinic, we have started now, for the last 3 or 4 years, measuring people's blood pressure, their blood sugar, etc., and then referring them on to general practice. We're starting to do more for our HIV patients. What hasn't happened, as much as we like, is that people have had an HIV test because they happen to have tuberculosis, or they happen to have shingles, or some other disease. So in Nigeria, they've integrated HIV into reproductive health service, Sexually transmitted disease and HIV management has been integrated in India, and in Russia they're starting to integrate harm reduction services, including overdose prevention and antiretroviral therapy. So it is happening. The governments are saying, look, we don't want to just see a bunker with HIV in it, and you guys are trying to do something. We want to integrate more and more and more. So, what about non-communicable diseases? Well, it's sort of the shape of things to come with non-communicable diseases, as you know, and if you go north of the wall, you can see a lot more people are looking that way. Now, people are living longer, and if they live longer, they're going to have more healthcare needs. Much more. I mean, you know, very few people reach the 7th, 8th, or 9th decade of life without having seen a doctor or developing a chronic disease. It's just the fact of us. You know, we're not sort of constructed to last without a problem for 90 years. Okay, and if you look at the life expectancy of the total population, these aren't HIV, this is the total population here, you can see it's around anywhere between 70 and 80, depending where you are. It seems to me that people who live by the beach seem to live a bit longer, but probably not. But you can see women always live a bit longer than men. So if our HIV patients who are well controlled on antiretrovirals are going to have more or less a normal life expectancy, we're going to see a lot more comorbid diseases. But before you look at this slide, I just want to say something about life expectancy. When they talk to us about an average life expectancy, that's all it is. That's all it is. In Glasgow, some of you go to that Glasgow meeting, between the east part of Glasgow and the west part of Glasgow, there's a 20-year difference in life expectancy. 20 years. It's absolutely incredible. Okay? So, and that's mainly related to poverty and lifestyle and poverty. And many of our HIV patients, remember, many of them are embedded in poverty with a lifestyle that's not healthy. We're trying to do our best to lift people out of poverty and to improve lifestyles. This is something from the US. This is, look at this, a small part of New Orleans, Louisiana. If you live here, life expectancy is 80. If you live there, it's 55. So when people talk about all of this, oh, you're going to live to 70, 75, you know, these are just averages. And in our HIV patients, it may be that their life expectancy is less, not because of there's something inherent in their HIV that may be playing a factor. Some people think that might play 1 or 2 or 3 years. But the major factors for our HIV patients will be their comorbidities, their lifestyle, their social class in terms of their poverty. So let's not forget that when we're talking about non-communicable diseases. If you look here, this is the estimated percentage of the adult population which is aged 50 years or over by 2012, and you can see here Latin American and the Caribbean, around 15% of your patients are already over 50. Well, there'll be more now because this is 2012. That was the last estimate. So that's quite, you know, maybe up to a fifth of your patients are now getting into a decade where health problems start to occur. And if you look at the burden of non-communicable diseases in Latin America, you can see between 1990 and 2010, because of the improvements in life expectancy because of health and economics, etc., you can see that there's been only a small increase in Argentina. In Brazil, it's a lot more, okay? And you can see in every country, really, and here's Mexico, you can see big increases, okay, in most of the countries. So, cardiovascular disease, stroke, cancer, and diabetes now represent the large share of burden in Latin American countries, accounting for 3 out of 4 deaths and for 2 out of 3 disability-adjusted life years lost. So if you have a well-controlled HIV patient who's living a life that they want to, you know, family, children, going to work, going on holiday and enjoying life, you can see that they will also probably end up with 3 out of the 4 of their deaths due to those diseases and 2 out of 3 disability adjusted. And cancer is the second most frequent cause of death in the Americas, with nearly 500,000 deaths. And HIV patients are aging, so these are going to be important issues. So HIV doctors in my unit, we have more 50% of our patients are over 50. We are spending a lot of our time with these NCDs. And as I said before about life expectancy, We have to control poor lifestyle. HIV patients smoke more, they take more alcohol, they take more recreational drugs, right? We know this, and they're often more in poverty than people who have not got HIV. So, I'm just going to show a few slides about how serious some of these non-communicable diseases, these NCDs, are around the world. So if you look at the metabolic syndrome, and this is a combination of a high cholesterol, being overweight, and having diabetes and having blood pressure. You put them all together and you say, okay, here's somebody, like on my first slide, the shape of things to come. How many of those people are ending up towards the guy with the soda in his hand, right? And you can see where the studies have done. A lot of studies have been done in Latin America, and it actually is from a few percent up to 15%. And there was a study here done, published here, but done from all over South America to show that males and females, you can see what percentage of people here have got high triglycerides, high glucose, low cholesterol, abdominal obesity, and hypertension. These are HIV patients, okay, that have been surveyed throughout Latin America. So we can't say everything's about HIV, because it's not. With an individual patient, it's not. And on a public health issue, it's not all about HIV. And you can see here in metabolic syndrome, again, if you can see at least 20%. It's a bit lower in Chile and Colombia. Okay, so there's a lot of patients who have either got obesity, they've got diabetes, they've got hypertension, or they've got raised cholesterol. So how could then, if we're going to say all these problems we need to incorporate into a universal health coverage, so if a patient comes to a clinic with HIV, we also ensure that their needs are met for all the other diseases, and we don't just focus on the HIV. And if an HIV negative person goes to one of these clinics, people think about HIV. How does all that happen? Well, there's got to be political and economic reform. And how many meetings have I been all my life where people say, we've got to change politics, we've got to change economics, and you'll go, oh, okay. And every 4 years, a new government comes in, and just before they arrive, they tell you they're going to solve all the problems, and then 4 years later, the next people coming in and tell you, we're going to solve all the problems that those guys promised to solve 4 years ago and have done nothing about. Having said that, that's a bit unfair, because we do get, in a lot of ways, stepwise progress. And I advise you all to read the series in The Lancet about healthcare in Latin America to show actually how fantastically you've done in Latin America overall. It's not perfect, nothing is, how you have done over the last 20 years. So, political and economic reform. Now, improvement in outcomes and utilization. And I heard the stuff about PrEP, right? How are we going to measure the outcomes? How are we going to improve the outcomes? How are we going to use things well? And it shouldn't be necessarily shared across income groups, because poor people might have very different needs. Their improvements in outcomes and the use of it may be different to the rich. Improve financial protection so that you don't have to pay. Public funding and how it's spent matters. And when people say we can't afford healthcare, I'm afraid we can. And we can't afford to pay tax for healthcare, I'm afraid we can. Most people can still go out and buy a coffee from a shop, whereas if that money went into healthcare and you decided once a week you weren't going to spend it on that, and the money was used well, we could easily afford good healthcare. So how we public fund and how it's spent is matters. Now this is a LATAM region, and I don't expect you to read all this, but this is all the different public, social security, and private and other, all the percentages of the entitlement and public health coverage. And it's great because universal entitlement to health, universal coverage of basic health care, universal coverage, etc., and I don't know why the countries have disappeared, but they have, along many, many countries that we have. So, the LATAM region has established health as a citizen's right. So you ought to be proud of this, actually. It's fantastic. When I was reading about the fact that as a region, you all say that health is a citizen's right, and it's in your constitutions, it's marvelous, because it's not the same everywhere in the world. In Mexico, it's slightly different. It's the right to the protection of health. Okay, and this model has embraced the idea of explicit entitlement. In other words, people are entitled to get health care, and they in the form of this. So will HIV be one of the things that we keep fighting for? You should be entitled to HIV care. Every single person who's diagnosed HIV positive should get HIV healthcare. And in fact, it's in your constitutions to say that they should. And can we bring PrEP into there? Can we bring other prevention into there? How do we make sure that that gets into this so that when we look at universal health coverage, we don't say, oh, HIV's in there, but we can pick and choose which bit of HIV we're going to deal with. You've already got all of these plans from whichever country you have, right, to be able to put HIV as a comprehensive health coverage into those plans. You can see here how the GDP is very different. All these slides will be available to you. How much is public? Some Chile, 40% is public for that, 60% in Argentina, etc. And you can see how the per person income is also in there, the GDPs of these countries. In fact, by increasing the percent of GDP into health by a small amount, almost everything you can afford. So Carlos gave me this yesterday. Would some countries lose HIV external funding? Because imagine you say, all of the HIV just goes into the global healthcare. Then people outside go, well, why should I be giving you any funding for HIV? It's now solely a government issue, right? So you'd have to find a way, if that happens, of negotiating with external forces like the World Bank, PEPFAR, etc., that the money coming in actually gets spent on HIV and doesn't just get spent into the whole pot, right? So it doesn't get diverted into diabetes, say. And you can see domestic financing for HIV. These countries, the impact wouldn't be big, but in some of these countries, the impact could be enormous if you decided to say HIV is just like everything else. Because maybe the external funding into this would either disappear or go into something else. But there has been, you can see in all of these countries here, in Latin America, increased investment in health over the years from 95, and the last time it was looked that I could get the data from was 2010, which is a long time ago. But in fact, you can see there have been increases in public health funding. What would we need to convince governments to do to ensure that the HIV public funding for HIV was adequate, was enough? One way is we can start telling them, everybody, that we should change the model of healthcare slightly, and we've already done this in a lot of parts of the world with differentiated healthcare. And in Africa, this is the way it's done. So we would say, learn from HIV. Our public health approach, we've got a good packages of care for everybody. We've decentralized delivery of drugs and other things. We've enabled scale up of services with high quality care. We've improved efficiency. But there are lots of obstacles, structural, psychosocial, and behavioral, to engagement in all this, okay? But by differentiating the care, we can do it. Why is it, if, say, you're a diabetic, you have to go and see a doctor to get a prescription for your drugs? Why is it, if you've got asthma, you have to go to the clinic to get assessed? Okay, why is it? With HIV around the world now, we're changing this. And these sorts of models of new healthcare might help all these other chronic illnesses. So we've already got a lot of missed opportunities. Some Latin American countries have launched national programs for early diagnosis of diabetes, metabolic disease, and cervical cancer. Have they said to people, do you want an HIV test? In the diabetic one, have they said, we want to measure your cholesterol? Probably yes. We want to measure your weight and height? Yes. But have they said, how about an HIV test? Probably no. And the same for cervical cancer. Is every cervical cancer, and that's really important, we need to test you for HIV. So there are some missed opportunities. There certainly are in Europe. But also, the other thing is, we haven't used the opportunity for these facilities to do all sorts of HIV counselling as well as testing. And if you're HIV and you go to a centre that's dealing with diabetes, why can't they talk to you about your HIV treatment, your adherence? Okay, why can't they have some training in saying, hey, how's it going? What's happening? Do you need to go and see someone else? But eventually, one of the things that we have to ask ourselves is if HIV becomes a mainstream thing, so you go to your family practitioner, they deal with it, you go to the hospital, there's no more HIV specialists, everybody's looking after it, or the HIV specialists are only for the really complicated cases, like the diabetologists only now look after the complex cases. If all the people who are undetectable and going, if they don't see specialists anymore, will we lose out on the skill sets? All the nurses, all the healthcare professionals, all the pharmacists who invested a lot of their careers in HIV, if they all sort of become de-skilled, what will happen? And where HIV services are well developed, should they also manage diabetes, asthma and things? So in your NGO, maybe you've got a place where people come. Are you going to start talking to them about other diseases? Is that important now for all NGOs which are HIV specific to address HIV lose special status for funding? I've already said that. Will external funders go, no, we don't need to give it to you because now it's all in the mainstream? Will drug costs rise or fall? Okay, so that's the other interesting thing. What will happen to drug costs if that's the issue? And will HIV survive as a specialty? And remember that one of the things that will drive all of this, okay, racism, poverty, gender and stigma are driving all of this problem in terms of HIV, and we are trying to address them. If we move into the general health market, will all of these issues be forgotten? So, finally, if we're going to integrate HIV into universal healthcare, we need to move beyond just delivering healthcare. We have to address all of those challenges, especially around stewardship and financing. We have to include initiatives to deal with these unfinished agendas, especially around stigma and gender. We can't lose sight of these because we happen to have a more comprehensive health service. And we must include both comprehensive personal health service and interventions. And these interventions must address the social determinants of health, some of which are very specific to HIV. The transgender issues, the sex worker issues, etc., have got a very big basis inside HIV. So it's up to you guys. Where do we move to? Do we keep our special status, or do we just say it's about time we've finished with AIDS exceptionalism and move into general healthcare? Thank you.
So thank you for this wonderful talk. We just have 5 minutes for 2 questions, quick questions.